Well, people will come in, but I think we should get going out of respect for those who arrived on time. My name is Russell Lupker, and I'm in the Division of Epidemiology and Community Health at the School of Public Health. And we are fortunate to have our 22nd Carl Martinson lecture. This is an endowed lecture devoted to issues of health promotion and disease prevention, topics that were central to Dr. Martinson's beliefs in clinical practice. Next. Carl Martinson was born in Stillwater, Minnesota in 1888. He was the child of Swedish immigrants. He graduated from Union College in Omaha, Nebraska in 1913 and taught chemistry in high school and college for 9 years. While teaching in Chicago, he became acquainted with Dr. John Harvey Kellogg of Battle Creek, Michigan. Dr. Kellogg encouraged Carl Martinson to go to medical school. The name Kellogg and Battle Creek, Michigan may have some connection for you. But I read up, this is an aside. I read up on this that he not only patented cornflakes, but he patented granola. That patent is expired. But he did it because the people in his sanitarium he thought needed better nutrition. So that segues into some of the things that Dr. Martinson taught and did during his practice. So he graduated from Loma Linda in 1925 and moved and did an internship at LA County in Los Angeles, and then moved to Minnetonka. And you may have seen at the very beginning pictures of the Minnetonka Clinic and the Martinson Clinic where he practiced over 40 years. He long stressed good health habits and as a means of preventing disease, an important lesson today, as it was then. From the beginning in 1927, Dr. Martinson's clinic was smoke-free. You have to remember, this is 1927. This was not a common thing. And I usually say it took University Hospital till 1985 to have a smoke-free environment. So he was way ahead of his time. Some of his family, Tom, Joan, and Bill, Tom, Joan, and Bruce Martinson are here today, and we welcome them. They represent the family and the Martinson Foundation. So we're fortunate today to have Dr. Steve Kelder. Dr. Kelder graduated from, if I can have the next slide, from Northern Illinois University, but importantly received an MPH and PhD from the University of Minnesota. After graduating, he moved to Texas, where he became an assistant professor and also the program officer for the Texas site for the CATCH program. And CATCH, for those of you who don't know the acronym, stands for Child and Adolescent Trial of Cardiovascular Health. Steve has published extensively in nutrition, physical activity, obesity, and obesity among youth, as well as other things. He has been supported consistently by the NIH, by the state of Texas, by the CDC, and other organizations. He has received multiple honors and awards. One that I picked out is that he was a senior editor for the Surgeon General's report on e-cigarettes, an important contemporary topic among youth. But he also founded the CATCH Global Foundation, which has worked over the years to extend CATCH to broader topics of health education among youth and more contemporary issues like e-cigarettes. It's quite extraordinary what he and his colleagues have done in Texas. I invited Steve for many reasons. I thought people should hear about Catch, but I also, many of us do community intervention programs. And we all fill out the little blank, how would you disseminate this after you do it? Assuming it's positive, which is not a good. And we sometimes fail in that because we're on to the next grant and there's no support to do dissemination. Well, at the Texas School of Public Health, where Steve is from, they have taken that seriously. And Catch is not only a vibrant and ongoing program, but it's also gone worldwide in addition to just the United States. So Steve is going to talk today about 38 years of Catch. It's frightening. From a randomized controlled trial, which the NIH generously supported for us and some of the people in this room, to mass dissemination. So welcome, Dr. Kelder.
Well, thanks, Russell, for that nice introduction, and thanks to all of you for being here. What a nice crowd. You know, in Texas, sometimes it's hard to get actual people in a room. But you guys seem to have achieved that, so good for you. Oops. Just a minute. So it's a pleasure to be back in Minnesota, and yes, I graduated in 1992. I'm pretty sure I had brown hair back then, and Texas does things to people. You live down there, and to see Leslie and Russell and others who were here when I was here, especially Henry, and it's just kind of, to me, it's amazing. Minnesota was a formative years of my life. You know, as Russell said, I graduated from Northern Illinois, but I had a business and economics degree. I first worked for Xerox as a salesman in Chicago selling copiers. And then I thought, I don't know if I like sales, but I'll go into medical sales and I'll make a lot more money. And I did make more money, but I didn't like that either. So I thought I'll just go to University of Minnesota, and the rest was history. I mean, I just picked one university. I'm going to Minnesota. I don't care what. And I just worked my way to get into here. And that's partly why I'm here today. With all the training that I had from everybody, it was such a great experience. Whoops, how come this is not going? Oh, sorry. Just got to put back in that window. There we go. Ah, there we go. So I just want to recognize a few people that I learned from and that were here when I was here. And I was so fortunate that I actually worked as a GA for most of these people. And they taught me, you know, different elements of epidemiology, analysis, paper writing. I remember sitting with David Jacobs with my first paper. It was on the design effect from the Healthy Worker Project. I'm like, what is a design effect? So he taught me how, and he would have me look over his shoulder while he was writing. I'm like, how can you write that fast? Just long, the paragraphs are perfect. So anyway, thank you very much to everyone here. Knut Inge was a student back then, and I particularly like this picture because it looks like a horror movie and it's October. Okay, I have to thank so many people are involved in Catch. There are literally hundreds over the years because lots of students and GAs and faculty and people all over the place. But my wife, Deanna Helsher, we work together. She's the dean of our Austin campus. And together we did a lot of this work. And you know, when your spouse works in the same area, you work all the time because, did you hear this? Did you read that? I just got an email. Anyway, we've been doing that for a long time. She deserves as much credit as I do, but it really is a lot of people who are involved in this. Oops, wrong way. There we go. So here's just a brief tour of the grants that we got from Catch. And so it started in 1987. I was here, actually, I worked as a GA on one of the projects for no smoking in hospitals, Russell, back in 1985. So I'll take a tiny bit of credit for kicking that off. So we had 5 different grants from NHLBI. One, they were sequential and over time. We had a lot of funding. It was a great time to be a young professor working with some of the best people across the country and publishing lots of papers. And then the blue starts with, the grant's over, we started writing other grants. Most of the other investigators had other things they were interested in and kept doing it. And I think it might be my sales training. I just had to go out and sell this a little bit more. I didn't want it to sit on a shelf. So we got lots of different grants and expanded it. And now I have two more NIH grants at the bottom. Catch My Breath is an NCI funded trial, is just about done. And Catch Healthy Smiles is, we'll finish data collection in the spring. And so partly, the Healthy Smiles was NIDCR said, well, they were becoming interested in behavioral science. I learned how to be a behavioral epidemiologist here. And to me, it's a diversity of funding streams. So now I have another institute I can apply to grants for. So NCI, NHLBI, NIMH, NIAAA, and lots of foundations have supported Catch over the years. Oops, gotta figure out where that is. So if you're not familiar with Catch, it was sort of instrumental in thinking that maybe you can apply research and programs that are different. I mean, a PE program with a nutrition program at the same time. That was a new idea back then. And then to work with the other elements too. These are the 4 elements of Catch that were in the very beginning of it, which led to, some pretty decent results. It was powered for total cholesterol, and we did not meet that mark, although I will say it was a non-significant positive effect. But we had pretty strong significant effects across these various dimensions, which are related to cholesterol and blood pressure and other biological markers. I think the kids back then, they weren't as obese. Throughout my career, we've seen it just sort of skyrocket up, and severe obesity in Texas is in double digits with high school kids. It's a whole nother problem. And that led us to deploy a variety of diffusion of innovation strategies. And we have now Catch in half the schools in Texas, which I'm pretty proud to have. They do an annual survey of all the school health advisory councils in Texas. And so we consistently hit that 50% mark. And that, if you know diffusion of innovation, is about the innovators, the early adopters, and the early majority are about 50%. And so I haven't quite figured out how to get the late majority and the laggards to jump on board. Oops. So the School Health Index came along in my career, and that's from CDC, and it's a programs and policies system of self-assessment. So I got the job from CDC to look at all the best practices and guidelines and evidence-based rules for schools in different areas: smoking, diet, physical activity, asthma, violence, and injury. And through that process, I started thinking, well, maybe we need to do and change Catch to be more current, because, before you know it, the end of the 80s happened. It was created in 1987. So keeping up with new developments and new possibilities is something that it struck me hard when I wrote the School Health Index. And then came along dietary physical activity guidelines. When I was in graduate school, they didn't consider physical activity a primary risk factor. And that's partly because of the measurement techniques at the time. There's too much variation, so it would drop out of the equation and smoking would stay in. So, but the measurement techniques got better and better and better. And then my friend Bill Cole managed the physical activity guidelines. And in there, he said 60 minutes a day, because it's like, how much physical activity? Those numbers have changed a lot. How much vigorous, how much moderate, how much weight training, how much stretching. And so now we had a target 60 minutes a day of physical activity. And so I started, whoops, I want this one. So I started thinking, how can I talk to schools to try and let's see if we can get all 60 minutes at school, first in elementary schools, then in middle schools. So then I looked up research, and at that, well, I forget when I looked that up. These are old slides, new slides, line slides. So there has been research, let me say it that way, that kids won't walk farther than 15 minutes. Once you go past 15 minutes, they're going to get on the bus, they're going to have mom and dad drop them off. That might be a little old. It might be 2 minutes now, or it might be never. But back then it was 15 minutes. So I thought if we can help children decide to walk to school for 15 minutes and then back, we get 30 of those 60 minutes. So we encourage schools to do that. So why is that a problem? some neighborhoods, you don't want your kids to walk, especially when they're in third grade. And so out of that, and I won't take credit for it, but the walking school bus came along and other techniques where parents would volunteer and they would walk kids to school. And so that fit into this. In physical activity, they usually have an hour, sometimes an hour and 15, hour and a half or so. So even if you have the best physical activity program, the guideline is 50% of the time available for physical activity in schools is for moderate to vigorous physical activity. And so that means maybe you can get 20 minutes in physical activity. So physical activity, PE alone won't get you the 60 minutes. It'll get you closer. You get a nice dose. You might get kids used to trying different things and being outside, and every kid's a little bit different with their own level of ability and competence with sports. So they do an important job, but they can't do the whole job. So then I started thinking of recess with elementary schools. That was when George Bush was president, and he put in the national standardized testing. So many schools were eliminating PE, they were eliminating art, they were eliminating music. So we lobbied in Texas and got mandatory physical activity carved into stone in the state education code for that reason. And so recess now, not now, but those are another 20 minutes. So we created playground markings so that kids could be playing games, hopscotch, and go back to the things that we remember when we were kids. And then after school, there's plenty of time. So we developed an after school program because more and more kids were in after school programs, either at the YMCA or on campus. So let's get them physically active, and we can also teach them about dietary intake. Then they walk home, and then they have a lot of time in the afternoon. So I just guess 60 minutes after dinner. Why not? So, you could get all of it after dinner. You could get all of it in different areas, but we started developing programs and trying to figure out how to get the kids up and walking as best we could. Oops. So then I had a dilemma. It said, how much nutrition education is enough to get behavior change? That turned out to be kind of a difficult problem, but I had heard from my nutrition friends, probably Leslie told me this, that you need 82 minutes a week or 50 hours a year of intense nutrition education to get dietary changes. I couldn't really track that down. It's in journals, but it's not referenced. So I'm like, oh, what's going on? So I did a review of the programs that were funded by NCI with the 5-a-day program and then the Catch program. And it appeared as if 25 hours a year or 41 minutes a week, 8 minutes a day. So then I started thinking, well, can we get a minute of nutrition education a day? And I convinced schools to do just a tiny bit of something. And then what form could it take? Did it have to be a classroom thing? Or it could be the morning minutes. So we created announcements that the kids could talk about. Some kids are extrovert and they want to get on the microphone and tell the whole school something. So that's, you just get creative and start thinking, how can you fill that time? And slowly over time, schools there's more content now. Computers came about during this time, iPhones and iPads and many, many other things. So it was harder and harder to get class time. And that forced us to figure out ways to get this messaging out outside the classroom. Oops. So that led to Catch 2.0. So we eventually got some funding to upgrade all the materials and try new things and create new programs. And then Michael and Susan Dell found us in Houston. And one day in walked Susan Dell and her PR person or whatnot. And we have a meeting. She said, would you like to come to Austin and start a child research center? Because they were starting to give grants in the health arena. They'd given lots of money in engineering and STEM education, but not in the health arena. It turns out Susan Dell was a marathon runner and she had little kids. She's like, Michael, I want to divert some funds to this area. And, he was giving millions and millions. So we ended up, she said, will you move to Austin? I'll give you $4 million to start a center. Then she said, well, I'll give you another $2 million to put Catch in all the elementary schools in Travis County. There was 136 of them at the time. And we did. So of course we'll come, Deanna and I. So we did. And that started that off. And that gave us the resources to update. If we're going to talk about dissemination, it's not just one thing. The programs, the children move, the school systems move, they change. You have to keep up in some way. So one of the innovations we had was a coordination kit. You know, Catch has a certain number of programmatic elements that we say they need to be intervened, they need to be implemented. And then there's a long list of other things that you could do. Remember, I was telling you what about all the non-classroom stuff? So when we did a classroom training, the schools would get a little confused because you've got a giant list of things they could do. In addition to teach the classroom or do the PE. So we put that into what we call the coordination kit, and we broke up, you can see in there, what's this? Oh, this is good, I can't read. One for the nurses, one for the PE teachers, one for the third grade teachers and fourth grade, and the school administration and the parents. And so what we did is we calendarized all these different things, and we would give them and we broke it up into 9-week segments, which is how the school years are broken up typically in content areas at schools in Texas. So we said, well, at the beginning, plan, prepare, and then in this month when September starts and the school starts, have a kickoff. And so the schools, if they were doing it well, and they were doing it coordinated, they would have assignments for lots of people in the campus to try and do certain things. And some were easy, some were a little bit more intense. Some required full-blown training of the PE teachers, for example. And that's how we did that. That turned out to be popular. Oops. I'm gonna let go of this one. Oops, this is the wrong presentation, but I'm gonna keep going. I had a couple of them. This is not the one I practiced this morning. I want to give you a little Texas data anyway. And so Deanna runs a surveillance study called SPAN, Survey of Physical Activity and Nutrition. Whenever Texas Department of State Health Services gives her money, she'll do the survey. And it's becoming more regular. I just wanted to show you that there's something happened in increases in grade 8 and 11, but decreases in grades 2 and 4 over the COVID period. So kind of scratching our heads, well, why is that? But the upward trend is pretty far up with the older kids, but less for the younger. And we're kind of thinking that maybe it's because they're at home and maybe they have less exposure to all the foods that they could be eating. Sorry, I'm going to skip through a bunch of stuff. Bear with me because this is not the one I thought I was going to do. I had to cut out the data because there wasn't enough time. Sorry, because this is a story about dissemination, not so much about data. So Deanna and I mostly meet with writing the grants. I wrote lots of grants, some to Blue Cross Blue Shield, some to other health insurance companies, some to local foundations in Texas. And I think in other parts of the country, there's conversion hospitals. So public hospitals that got bought by private entities, healthcare entities. And in doing so, as part of the agreement for the sale of that, they had to start a foundation and have a bolus of funding that would go for community benefit. So I would call on all these places, and I say call because I was a former salesman. Call these places and just try and get money from them. Like, here's Catch, here's why it would work for you, here's the problems it might be able to solve, here's how many schools are doing it. And we got a fair bit of money from these foundations and other places. And that's what the comment of diversifying your funding. It's not just with NIH. So at that time, I had a nice portfolio of NIH funding, but then whenever it was starting to get low, I would get a foundation grant. And that's the way to keep the trained staff afloat over the years. So we created the Catch Global Foundation. I was writing this grants, and I had a talented student. He got his MPH, and he had retired at age 30 with the .com boom. So he and his colleagues invented, remember back then, a safe and secure internet connection for transactions. So the transactions, when you go to Amazon, you just have your credit card, or transfers or other things. They created that and sold it for $150 million, he and his buddies. So like, well, sometimes that happens, doesn't it? Not to us, it wouldn't be, but it happens. So he decided, he thought, I'm going to try and do something in the private sector. I'm sorry, in the public sector. So he and I cooked up this idea for Catch Global Foundation. I'd always wanted to do a foundation because I was being pretty successful in getting money from all these alternative sources, including CDC and USDA and other larger scale, RWJ. But I couldn't handle it all as a university professor with teaching and research. And of course, the institution wants the NIH grants with the 50 to 55% IDCs versus 10%. And so Duncan took over, and then something extraordinary happened. Dan and I were giving a talk at MD Anderson. You may know that cancer research centers also have a requirement for community benefit. That's something good to know, wherever you are at the Cancer Research Center. So Ernie Hawk invited me to give the catch talk, similar to this, but only 15 or 10 years ago. And after the talk, he says, you know, Steve, we're just about to create our own diet and physical activity program. What could you do with $4 million? Well, can you give it to Catch Global Foundation? And that was it. And all of a sudden, within 3 months of opening the foundation, we had $4 million. And then we went and asked a few more places and got $2 more million. Now we had $6 million to start this organization. And that hired the staff to once again revamp, revise, upgrade. But the biggest thing that probably helped us the most was we digitized all the curriculum so that teachers then could walk into the classroom, open up their Catch website, click the tile for whatever they wanted to do, and open up a PowerPoint set of slides, which had in the notes scripts for what to say and the reason why to say it. And they really liked that because, believe it or not, a lot of teachers don't want to teach nutrition because they don't know anything about nutrition. So it became a continuing education process with teachers, and we did that through our training. You can't teach all of nutrition in an hour or two during a once a year training. So that's how we sort of snuck in teacher education through these slides. And that ended up costing a fair bit of money. I think we spent $500,000. You know, it was trial and error because the databases weren't as user-friendly as they are today to be able to do that. We had to go from one company to another. So then it was the university was creating new programs. They would get registered with the Intellectual Property Office, and then Catch Global was licensed to distribute them. And, you know, we're all getting a little bit older, and I've got gray hair, and I'm thinking, I'm the guy who's writing the grants. When I go, this whole Catch thing will collapse and it'll be over. But now that's not true because he's hiring some of our students that I've trained in NIH grant writing and that have a broad understanding in public health to be competitive with these other agencies like Blue Cross Blue Shield, etc. So we started creating other things too, as Russell said. So we had comprehensive health, physical activity, nutrition, and then social emotional learning was coming along as a concept, as a topic. And many schools are implementing social emotional learning. I thought, that's a health and wellness thing. Why shouldn't we take our curriculum and redesign it to include elements of social emotional learning? So that took hiring people that knew more about it and then revising it. It comes at a time when the nutrition standards are changing. You know, in fact, my wife, Deanna, God bless her, is working on the dietary guidelines right this week and had a meeting and they decided, maybe I shouldn't tell you this. She'll get in trouble, not me. Anyway, so it was a public meeting and they were considering increasing the dietary servings of fruits, of beans and legumes and decreasing a serving of meat. In Texas, that's sacrilegious. It's a barbecue place. And they immediately got hate mail and just, yeah. So anyway, I don't know why I told you that. Emotional learning, substance misuse. I'll tell you more. I'm going to finish this talk with Catch My Breath, the e-cigarette program that I wrote and we disseminated. We've added other substances, alcohol to it, fentanyl when it crept up to be such an awful thing and the death rate. And unfortunately, my nephew died in the streets of Chicago from fentanyl. So it's kind of personal for me. So I wrote some lessons on fentanyl. At the very least, make the teachers aware. At the very least, make the parents aware. And then have at least 1 or 2 class periods around the dangers of fentanyl and how it can virtually be in anything. If you take a drug at a party, you just don't know. So we did that. And then oral health, I talked a little bit about that. That was serendipitous that I met the project officer and they wanted to take a turn into behavioral things. Sun Safety, MD Anderson had that program. So that was a program designed and implemented and evaluated by another group, but we added that to our curriculum. Texas is kind of hot. There's a lot of outdoors things. So then we added stronger and more family and community. And at the bottom, it's academic achievement. So academic achievement is a new element to catch. We're just going to add a new section to it. So we hired a clinical psychologist who's on the faculty, or was on the faculty at UT Austin. I was able to attract him into our department. He wanted to be with us partly because he created this program called Finding Focus, which is a personalized digital program where teachers can assign it. I mean, teachers will introduce it and talk about it, but then the child goes into it. He's using AI to customize what the kids hear based on their music preferences and other indicators of preferences. And in 3 randomized trials, he's shown increased focus and attention, increased academic achievement, significant, and reductions in anxiety and depression. He came to us because of Catch's distribution. So now we have a database of all the state health department officials over health in the whole country. In the large school districts, we have a database of them, and we've got thousands and thousands of teachers. So I can release this and say, we now have something for anxiety and depression that merges in with social emotional learning. What are schools interested in now? They want to get the kids back. The kids can't focus because of COVID and the tablets and all that other stuff. So I'm very excited. It's going to come out real soon. But that edition is now giving us another reason why schools might want to visit our website and learn about all the other things. And oddly enough, maybe not oddly, in Texas, with the state education code, there's so many required things, many more required things than schools could ever do. So you can't have a classroom piece for every single thing. And another thing that's a bottleneck is if you have lots of different programs, there's lots of different purchase orders and a lot of different companies to do business with. So all of a sudden, the schools wanted one vendor for these things and not 20 vendors because it's much easier on their personnel and their purchasing systems. So we kept adding more and more things to the Catch portfolio. We tried our best to find evidence-based, RCT-based things. Some of these are best practice-based and borrowed from the CDC guidelines and the other things that put that in my head from the School Health Index. So that's been fun. I'm going to skip through. So here's what it would look like if you go to the Catch Global Foundation website, and you can just go in there, click a tab. Kids Club is after school. Catch Kids Club, ILSI funded half of this, and the Paso del Norte Health Foundation Conversion Hospital funded the other half. Set social emotional learning journeys. That's a specific program just for SEL. So we have the only SEL and then the only in the SEL with diet, physical activity, and all these other elements. Here's the Educators Club, where there's kind of a bulletin board. Teachers can talk to each other. Catch My Breath, the smoking prevention, alcohol, fentanyl, early childhood, that's the pre-K stuff that we do. Catch Healthy Smiles, and then the sunscreen. So it's expanding, and because of the expansion, people hear about it. And we'll get to that in a second. So for a long time, I was using diffusion of innovations, but now there's something called implementation science. So it's similar, but it's different. There's different nomenclature, and it's more defined. So I mean, diffusion of innovations gives you broad frameworks, and you work within those frameworks, or at least that's the way we did it. So we just started doing a lot of different things and put it in that coordination kit and in our training. Implementing science is trying to be much more structured and systematic and create an evidence base of what works and what doesn't work. This is for what's called the sister strategies. And it's based out of the NIDA drug and alcohol literature. That's how do you implement things? They've done a good job with that because SAMHSA requires drug education. All these different elements broken into these different categories, from financial strategies, how do you get money and who's going to pay? How do you train schools and stakeholders to become interested in it? So I got that framework because we're writing a grant to transfer Catch to India. And the specific aim is, well, how is India different than Austin, Texas? Well, there's a few differences. And so I wanted to be systematic about it. So we picked this framework. So I sat down recently. Oops. I'm done. it turns out we did all of these within the Sisters framework just by basically trial and error. And if it worked, we kept doing it. If it didn't work, we chucked it. So it was a sort of this iterative process of how things go. And we got almost all of them. We have some curriculum or pragmatic or ways of training the other sites or things that we do ourselves. And so I'm very happy about this. So that's what happens when you do something for 40 years in a row. So I want to get to catch my breath. So as Russell said, I was invited to be on the 2015, was it 14 or 15? 15, Surgeon General report. I remember that because we really wanted it to get published in case Trump was elected back then. And the word was he was going to sweep all this stuff off, and who knows what would happen. Just like the dietary guidelines with Deanna, they're working overtime to get this done in case, well, I don't want to be too partisan, but never mind. So I was the senior scientific editor, as well as Cheryl Perry and Melissa Harrell, both from this institution. So we had strong Minnesota representation. I was in charge of the health effects chapter. So that's my behavioral epidemiology. And I had just a fantastic time learning about what it is and what it isn't. And, in 2014, we had limited information and no long-term information about it. But I found enough. The main thing is it's addictive. And there are studies that show that if you're addicted to one thing, vaping, you'll start smoking. If you start smoking, and the addiction level is much higher, and it can happen faster than with regular cigarettes. Cigarettes were going down anyway. So I wrote this, and out of the blue, CBS says, well, you're doing a smoking problem. At about the same time, they stopped selling cigarettes. So they were funding communities with prevention strategies about smoking and cessation in their clinics for nicotine. So they called and said, would you guys like $4 million? I don't know why 4 million is always a number. But if you would circulate this in the areas where we have a heavy CVS presence, we'll give you $4 million. So then we were able to fully build out this Catch My Breath program, which was, in the usual style. It was on paper, it didn't have a lot of graphics. So the production values went way up because they hired Discovery Education and a media firm to do so. And we had a lot of luck with Catch My Breath. Oops. What I was going to say is that I was also an expert witness in the Juul trials. And this is my community health education part, my master's. I was charged with writing what's called an abatement plan. So Dr. Kelder, if you had all the money in the world, how would you take e-cigarette rates down? And so I set the index at 4%. That was my goal. I didn't think I can't get it down to 0. I mean, no one can do that, but 4% seemed like a good number. And then as I was writing it, I looked up all the evidence-based tobacco and child and other things, put that into there, which includes media and working with state laws and all sorts of things, including classroom curriculum. Probably the minor piece is classroom, but the media and laws and the price changes and so on. If you know tobacco literature, it's pretty well, put together. So my program was in the billions of dollars when you put that across the whole country. And I remember talking to lawyers and this is just getting too big. He said, no, just do what you want, Steve. And so they won $750 million in a settlement. So now a lot of communities, I was able to speak to all the attorneys in the local communities through a webinar and promote Catch My Breath, which still is the only behavioral evidence-based program. So now I was able to help find the money to pay the schools to buy the program. And by the way, Catch My Breath is free. We decided the program's free. There's online training, but what we charge for is if a school district wants in-person training, because people to do it, I had to pay their staff. So it's a win-win-win all over the place. I was happy to stick the knife in Juul, to be honest. So here it is at a glance. The first draft was 10 lessons. Cochrane Review of Tobacco Prevention said 15 lessons. So I thought schools won't do that anymore, and that review's old. That's the old days. I mean, Catch had 25 lessons for 3rd grade, and I think 30 for fourth grade, like, there's just no way. We had to shrink it all down. So I have that database that I told you about. So I just sent out a little Qualtrics survey. Is vaping a problem? Yes. Would you like some solution? Yes. Would you be interested in a program? Yes. So I wrote it as I was reading the literature on the health consequences and writing that chapter. So I'm going heavy duty epi science and then writing program for middle school kids. It's both sides of my brain were just going crazy. That was very fun. And it turned into this program. The 10, they said, no, we'll never do 10. So I had to slice the lessons down and I had to really seriously hone in on, well, what are the primary risk factors? This is what Cheryl Perry told me. If you want to do a program, find out what the most potent risk factors are. And if the odds ratio is 4, the next one's 3, 2, 1.5, you go with the 4 and the 3 if you have to, and get rid of the 1 and 2. Well, that made sense. So I'm looking at the lessons. I'm trying to figure out from the literature. There's a ton of smoking prevention literature. And so we shrunk it down to 6 lessons. They said, no, too long, can't do it. Then we got into 4 lessons. So then I'm really at the odds ratio 4 and 3 stuff, and everything else goes. And that turned into the program. So it's 4, now what we call core lessons. And just like I learned with Catch, what are the companion pieces? And so now we have 5 other lessons. So we say schools, teach these 4 lessons. That's the basic. If you have time, teach these other 5 lessons. With the 4s with the same teacher, same students. There's a few STEM. So here's what you can do in science. Here's what you can do in literature, in reading. Here's what you can do in social studies. Then we developed a web-based version of Catch My Breath. So the teachers now can assign it to the kids and get all the content. Then we developed videos for parents, which mirrored the content, but also had strategies that were effective with parents. So that's now the new strategy: is a smaller number of core lessons and a wide variety of alternative stuff that might not be in the classroom, but it could happen in other parts of the school. And kids in middle school also like to read the announcements, the extroverted ones. So before you know it, Catch My Breath is in every state in the country. And we're training. So we started a train the trainer program. So there's people who are funded by SAMHSA, or they're in the health department, they're within the school systems. They come from lots of different areas, but we have trained, I think, 1,500 train the trainers, and their job is to go to schools, so we don't have to. They like it that their mandate is to do something with substance use, and that's what they like. And so they're out and talking about the program, and that was probably the biggest thing which got this whole thing circulated. But one of the things that happened was SAMHSA selected our program, because I did a pilot study, of course, before I did all this stuff, had very strong results that mirrored almost exactly what you'd expect from 6th to 8th grade from smoking, from my dissertation, from the class of '89. Like, oh, here's the same difference in the same age range. I think I'm onto something, partly because a lot of those curriculum elements come from what I learned here with Minnesota Smoking Prevention Program, with Cheryl and Dave Murray and Phyllis and the others. So yeah, so we're in all these different districts. Other things which have happened, no, I'll get to that in a second. Almost done. Oh, well, this is where it got a little bit out of order, and I reordered things this morning and I got the wrong presentation, version A versus version B. I don't know if that's ever happened to you. So this is the year I graduated high school, and the current smoking rate was almost 40% of kids. There's high variation. I grew up in an area where all the parents were in construction. They were building the suburbs of Chicago. I would guess it was 75%. Kids that ever tried smoking in 1976 was about 80% of kids had taken a puff and tried it, 40% nationally-ish. And then, things happen. There's prevention, there's policies. We learned a lot. Then the master settlement happened, and that unlocked lots of money for states and unlocked lots of policy solutions and the literature. And there's just a well-done field of tobacco prevention. I think we know what to do. And that then and then here's when the funding got turned on. At the beginning, most of the states would use their tobacco money. They get an annual supplement, sometimes in the millions and millions of dollars, depending on the size and population of the state. Nowadays, most states put it in general revenue, which is unfortunate. But some of them have continued, and now the rates are down, down, down. And then right around here, I started thinking, well, we don't really need to do tobacco research anymore. We know what to do. I mean, the NIH wasn't funding it very much anymore. Down, 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 and up. There comes e-cigarettes. Actually, they came here. They became popular when Juul entered the marketplace, and then it spiked up to, what was that? Sorry, 25% are current users of e-cigarettes. This is from the Monitoring the Future data. The CDC data is even higher at 30-some%. But I wanted to show monitoring. And then here COVID hit. This was during the lawsuit, and it dropped from here to here, and they say, well, Dr. Kelder, it's going down. Why are you suing us? It went down even more. Dr. Kelder. Well, it's going to go back up. It's just COVID. This is a social behavior, and they're stuck inside the house, and they're not going out, and that's how this whole thing starts, because with an e-cigarette, it tastes really good. It doesn't taste crummy. It doesn't leave a nasty odor on your clothes or in your breath. You take a puff of Boston cream pie, like, this is great. And the kids didn't even know it was in it anyway at that time. So that's what the program was designed to teach them, that there's actually nicotine in there, and there's downsides of it. A lot of the downside is now social. If you get caught, in Texas, there's a state law happened in 2023. If you're caught with an e-cigarette, you have mandatory alternative school. Now imagine that. What does that mean? No more football. So there was rebellion afterwards, of course, in Texas. But, cheerleaders, people in different squads, different sports, different everything. Now they're in alternative school. And who's in the alternative schools? There's two kinds of people alternative schools. And that's kids are doing bad things, maybe selling drugs or disobedience or, control issues, and pregnant girls. So let's send all the kids who just happened to have a puff in the bathroom and gotten caught to do that. Anyway, now it's going down. It's a social behavior. After COVID, it went back up. And thankfully, it's coming down because there's a lot of work with the Truth Initiative, and schools now have programs. I'd like to take, a fraction of credit because our program is in every state. But look at where smoking is. 1.7% now. And let's just be happy we're in public health, and it happened because of our field of public health, and it took a good long time, but 1.7%, that's a dream to be able to be in a profession and be there like I have, and Russell and Henry. You would never guess that with MHHP to get down to 1.7%, not back in the late 80s. Anyway, quite a success story. I thought you might like to know that part. That was my one data slide in the other presentation. I'm going to speed up because we're getting close to time. Oh my, this is very early version. Oh, here's the pilot study results. And not only did we see an effect with e-cigarettes, we saw current cigarette use go down too, or not be initiated. So that was a surprising finding. I remember talking to Cheryl and a few others and said, I'm just going to make a program just for e-cigarettes. You're like, no, Steve, that's not the way they do it. So there's smoking prevention. And then when little cigars came out, smoking plus little cigars, then hookah, then, snuff and other edibles, or not edibles, but oral health. I thought this is way too different and the kids are going to love it. And well, unfortunately, I was correct in that assumption. So I made this program is just for e-cigarettes, solely focused on e-cigarettes. The common denominator is nicotine. What is nicotine? How does it influence your body? What's addiction and all that? But other than that, it's all about e-cigarettes. And I didn't expect this. And I'm like, whoa, that's great. So American Lung Association now teaches Catch My Breath. They've trained lots of their people. American Heart is supportive of it. They haven't yet given us money. I judge organizations based on whether they give me money or not. I can't help it. I was a salesman. I was a salesman in North and South Dakota too, by the way. So I traveled every hospital in North and South Dakota, Western Minnesota, Northern Iowa, and Nebraska. And I would judge a city on whether they bought from me or not. Why not North Dakota bought from me? I like that place. So I'm going to stop here because we're getting close. This is the results from the RCT study that we got, a randomized controlled trial. We started recruiting schools as soon as COVID started. What a great time to be a school-based researcher. I didn't get the schools that were nice and localized around Austin for a variety of reasons. So instead, most of them were out west in Texas. And you know, the distance from Houston to El Paso, covering large span of Texas, is the same as Houston to Chicago. That's how big Texas is. And so now I got to pay staff to go all the way out to El Paso and start monitoring things. So we really did have to digitize things, digitize the training, digitize the follow-up visits with the staff. So it threw us for a little loop, and like we had a very poor response rate too, I must say. There's lots of limitations to this. A couple of weeks ago, we start looking at this. I'm like, well, what if it's non-significant? And what if it's a negative finding and it's in all 50 states and everybody knows about it? So I'm happy to say that didn't happen. So I'm going to stop there and take questions.